Hello, everyone. Thank you all for joining us today for this Lunch and Learn to hear and learn about some of the approved gene and cell therapy products from 2022. My name is Dr. Rachel Bailey, and I am an assistant professor at UT Southwestern Medical Center, where my lab focuses on developing gene therapies for neurological disorders, and we work with patient foundations, academic partners, and industry sponsors to translate these for testing in clinical trials. I am also the current chair of the ASGCT Patient Outreach Committee. So, this is the first official session of 2023. Our prior sessions provide general and more in depth information on gene therapies and the process in going from preclinical studies to clinical studies and then to FDA approved therapies. All previous sessions are available to watch on demand at patienteducation.asgct.org. This site also contains a whole library of Gene Therapy 101 and disease specific content that is free for all to access and share. There are disease specific units, including short animations, web content, and infographics for the diseases we are covering today. So please check them out after this session. Today, we have the pleasure of hearing from Dr. Alexis Thompson and Dr. Amy Waldman. They will go in depth about some of the recent gene therapy approvals and the disease population they affect, including Zynteglo for beta thalassemia and Skyzona for early active cerebral adrenoleukodystrophy. Please don't forget to submit questions under the chat feature during this session so we can hear what you want to learn more about during discussions with Dr. Thompson and Dr. Waldman. So starting off the session, we will have Dr. Alexis Thompson. Dr. Thompson is Chief Division of Hematology at the Children's Hospital of Philadelphia, or CHOP. She is also Professor of Pediatrics at the University of Pennsylvania Perelman School of Medicine and holds the Elias Schwartz MD Endowed Chair in Hematology. Her clinical interests include hemoglobinopathies such as thalassemia and sickle cell disease, and stem cell transplantation in pediatric patients, including gene therapy. Dr. Thompson has been an investigator on multi-center trials and as well as her own institutional clinical trials. Her most significant scientific contributions are clinical and translational studies to better understand and treat hemoglobinopathies. She has been a leader in multi-center collaborations such as the NHLBI-funded Thalassemia Clinical Research Network and the Sickle Cell Disease Implementation Consortium. She has served on regional and national advisory committees for governmental agencies, as well as for nonprofit organizations focused on improving healthcare access, increasing workforce diversity, and reducing health disparities. She was also the president of the American Society of Hematology in 2018. So welcome, Dr. Thompson.
Thank you, Dr. Bailey. I appreciate the invitation to join gene therapy for hemoglobin disorders and hopefully two additional ones that perhaps will come before the end of 2023. I'm going to talk primarily about thalassemia, but I would be remiss if I didn't also include sickle cell disease. These are both common blood disorders that are caused by mutations in actually the same gene, the gene called beta globin. They're inherited conditions. They're both autosomal recessive, and they're associated with anemias, but also with a wide variety of other complications. Fortunately, in the United States, sickle cell disease is identified universally by newborn screening for children born in the U.S., slightly different, obviously, for children who are immigrating to this country. And thalassemia is now also identified by newborn screening in many states. Both of these conditions can cause serious disability and risk of early death without early detection and proper treatment. For sickle cell disease, this begins with penicillin prophylaxis, which begins before children are 2 to 4 months of age. Pain medication when needed for the symptoms, the hallmark symptom of sickle cell, and now hydroxyurea as well as other disease-modifying therapies that seem to be having an impact long-term. For patients with thalassemia, the most severe transfusion-dependent form, they require monthly blood transfusions and then iron chelation to address the iron overload that's inevitable with transfusions. Now, there's a number of advances with disease-modifying therapy, but I'm going to focus today on really the curative landscape for the hemoglobin disorders. The ones that are most well established are the hematopoietic stem cell transplant approaches that involve allogeneic donors. The best data being with allogeneic related or sibling matched donors, but also advances with allogeneic unrelated donors and haploidentical transplants, and also ones with reduced intensity. We're going to focus on gene therapy because the recently approved product falls into that space. But also gene editing, we'll touch on that. Reprogrammed stem cells, we're not quite there yet, but certainly it's a very exciting area of research. We've now established that HLA-matched sibling donor transplants can and should be considered standard of care for sickle cell disease. The first one was undertaken in 1984 for a young girl who had both sickle cell disease and AML, and 30 years on, she is alive and well. This slide summarizes 1,000 patients globally, a compilation of a number of different studies that have demonstrated really remarkably low rates of chronic graft versus host disease and excellent overall survival in patients who are undergoing sibling donor transplants. The outcomes are somewhat better for children with sickle cell who are transplanted when they are younger, ideally before the age of 18. And in those who either have bone marrow or peripheral blood as their stem cell source compared to cord blood. When it comes to beta thalassemia, the first transplants were done in the 1980s, and certainly it has also become the standard of care for those who are fortunate enough to have a sibling donor, with really outstanding results. We, over time, have done risk stratification, so this is very early data with survival over 80%. It is now really closer to 90%. We actually stratify the lowest risk patients, and we actually consider age, organ toxicity, and the impact on outcome. We now are doing well enough that for sibling donor transplants, we can often do non-myeloablative or reduced intensity conditioning. Factors that affect transplant outcomes for sickle cell and certainly for thalassemia are the severity of complications prior to the transplant. And so the better health that an individual is in prior to transplant certainly is a great predictor of transplant outcomes. The source of the stem cells do matter. Certainly having a marrow and has had the largest number of patients and the greatest amount of success, but we're also seeing good outcomes with peripheral blood. Umbilical cord blood less so, and some of it is related to the actual total dose of stem cells, but certainly theoretically umbilical cord blood had certain advantages in terms of this being a naive source of stem cells, but by and large, for the most part, marrow and peripheral blood are the preferred sources. Availability of a sibling donor is certainly the preferred, and certainly there is research ongoing with partial mismatched and related, and as well as matched unrelated donors. I already mentioned preparative regimen, the conditioning, with thinking about myeloablation certainly being the most conventional approach, but now having increasingly good results with either reduced intensity or non-myeloablative. Age matters, which I'll show you on the next slide, and certainly the degree to which one has controlled iron overload also matters in terms of outcomes from transplants. This is a study that actually demonstrates what I was just mentioning, that children with thalassemia who have sibling donor transplants have the best outcome if they are done when they are young, less than 7 years of age, and before they have evidence of organ dysfunction. And many times iron overload causes hepatomegaly or liver enlargement. And so young children without liver enlargement have the best outcomes. Children who are older but who still have no organ injury also will do well. But certainly those patients who are older and have evidence of hepatic enlargement or liver enlargement, usually due to iron overload, cirrhosis, fibrosis, or chronic infections, tend to not do as well even with sibling donor transplants. There are a number of considerations. So I've touched on, for instance, donor availability. It's important to recognize that most patients with thalassemia will not have a suitable match donor. They will not have a sibling who matches, and unfortunately, many of them will also not have a suitable unrelated stem cell source. There are open clinical trials, but it must be recognized that allogeneic stem cell transplants are associated with a risk of a number of complications, including non-engraftment or graft failure, serious and sometimes lethal infections, graft versus host disease, which can also be a source of both um, illness as well as deaths, infertility, and transplant related mortality. Because of the lack of donor and the potential complications, this has opened up the field to think about other kinds of approaches, and that's where gene therapy comes in. What is gene therapy? In its most simple form, these are experimental techniques that use genes to treat or prevent disease, and that the patient fundamentally is their own donor, so it eliminates that barrier to undergoing a potential curative therapy. In the case of the hemoglobinopathies, currently they are all ex vivo. And what I mean by that is the patients actually have their stem cell collected, then sent to a laboratory where they undergo some type of modification ex vivo or in the laboratory before they are then reinfused into the patient, usually after a patient receives some type of preparative regimen, and I'll go over that. Gene therapy is actually an umbrella term. And so while I think more often than not it's used to apply to gene addition, and that's what Zynteglo is, gene therapy can also be considered when we talk about gene editing and soon base editing as additional forms of gene therapy. What will gene therapy accomplish? Well, in an ideal world, we'd love to replace the sequences at the site of the genetic defect. I will tell you that today that is not possible. But in theory, this is what we would hope to accomplish. Gene editing instead introduces copies of a normal gene, but leaves the native gene intact. It is also possible to use gene therapy to modify the expression of other genes that play a role in the disease phenotype or pathogenesis. And there are current studies that are actually in the very late phases of clinical trial development that do precisely that. And then finally, gene editing to directly repair specific sequences. For the sickle cell and thalassemia, the gene addition will add a normal beta globin gene. In sickle cell disease, it would convert those patients functionally to sickle cell trait because their native gene is still intact. But yet we know that patients with sickle cell disease or sickle cell trait, that they live a normal lifespan, typically with no symptoms whatsoever. And so this could really be a very tolerable and in fact desirable outcome. For thalassemia, we would want to reduce and if possible, eliminate the need for transfusions. Another approach has been to increase fetal hemoglobin because fetal hemoglobin is non-sickling in the case of sickle cell disease and is also capable of carrying oxygen effectively in the case of thalassemia. This can be done by adding the capacity to make gamma globin, which is part of fetal hemoglobin, to modify beta globin to make it more gamma-like because it has some other favorable characteristics, or to alter the expression of genes that regulate fetal globin. And again, these are all our approaches that are in the clinical trial setting. This is an overview of Zynteglo or Beti-cel, which is the therapy that was approved in 2022. As I mentioned, patients undergo hematopoietic stem cell collection after mobilization. Our stem cells are normally in our bone marrow in most of the long bones of our body. And that with adding the combination, giving the patients a combination of G-CSF, as well as a second medication called plerixafor, those cells can be mobilized temporarily into the peripheral blood, which will allow them to actually be collected using apheresis or an automated exchange procedure while the patient is awake, but briefly in the hospital. Once those cells are collected, they're sent to a centralized manufacturing facility where CD34, or the most primitive of stem cells, are selected and then exposed to a lentiviral vector that contains the beneficial sequences, in this case beta globin. Once the transduction or the transducing procedures are completed, the cells are cryopreserved or frozen and then tested for safety. The patient, during that time period, however, is home doing or going about their lives, going to school or work. but then they are hospitalized once their frozen sample is available, and they undergo myeloablation with a chemotherapy agent called busulfan. They're given as an IV infusion over about 4 days and then a few days of rest. After those procedures, their drug product, which is their own stem cells with the new beta globin gene being introduced, are then infused in an IV in a matter of minutes. The patients are awake, and this procedure is done without the patient really having any appreciable side effects. The patient does, however, stay in the hospital because they will experience some of the side effects of busulfan, and so they remain in the hospital until they overcome those side effects, which I'll talk about in a little bit, and until we see evidence that their bone marrow is now working. So that chemotherapy is to really make space in the bone marrow, which is otherwise packed with the abnormal thalassemia precursors. And it also reduces the number of cells that they have that are their own native stem cells that are making defective red cells. And so hopefully by the time they're discharged, we see evidence of their stem cells having engrafted and then creating functional red blood cells that now have incorporated gene therapy derived beta globin. And in the case of Zynteglo, it is tagged in a way that it actually makes a modified hemoglobin A or adult hemoglobin that's called T87Q. The benefit of that is that I can actually see that with a fairly conventional laboratory test so that I can distinguish between hemoglobin A from the blood bank versus hemoglobin A T87Q that a patient undergoing Zynteglo can now make on their own. These are the results of the phase 3 trials, which are now nearing completion from Bluebird Bio, who is the manufacturer of Zynteglo. And what this is showing is that both adults and pediatric patients, each one of these bars represents an individual patient, and you can see the ages of these patients, but looking at either children or adults. The very light blue is the period after gene therapy where they still are requiring some transfusions. But that you can see by and large that when patients become transfusion independent and no longer need transfusions, that they really do not go back to that state. And so the darker blue line demonstrates a continued period of transfusion independent for patients. And so in the phase 3 studies, nearly 90% of patients in these trials achieved this milestone, and they continue to be transfusion independent. In the initial trials, the earliest patients are now up to 9 years out, again, continuing to be transfusion independent. So the durability for Zynteglo is quite encouraging. It's also worth noting in the phase 3 studies that many of these children and adults are maintaining hemoglobins that are nearly in or are in the normal range. We had great news last summer, and so in June of 2022, the FDA's advisory committee examined whether or not the evidence, such as it was sufficient to answer the question: do the benefits of Beti-cel outweigh the risk for the treatment of subjects with transfusion-dependent beta thalassemia? There was a unanimous recommendation by these advisors for approval, and the FDA announced, in fact, approval for commercial use at the end of the summer. The decision pathway that most of us think through are acknowledging and identifying those patients who have transfusion-dependent forms of thalassemia, and then making sure that they're otherwise eligible for transplant in terms of their overall health. For patients who are under 14 and have a matched sibling donor, they really are or should be considered for an allogeneic stem cell transplant, in large part because of the large amount of data to show that that approach is safe and by and large effective. However, if they don't have a matched donor available and they are older, Beti-cel for the first time provides what I think we are seeing is a safe and certainly effective way to achieve many of the goals that otherwise would be achieved with an allogeneic stem cell transplant. Eligibility for Zynteglo requires that a patient with beta thalassemia be on regular transfusions. However, there is no restriction in terms of the subtype of beta thalassemia, and that the research studies were done in all genotypes. And so whether someone has what's called a beta 0 genotype, a beta plus genotype, or variants like hemoglobin beta E, all of those are eligible for treatment with Zynteglo or Beticel. And the FDA approved it across all ages. In the clinical trial, the youngest patients were down to age 4 and up to age 37, but the approval is not limited to any particular age. Patients must, however, be otherwise suitable for stem cell transplant, and that speaks to their general health. I'm going to switch briefly to genome editing only because we fully expect that there may be an approval for something very similar within 2023. They're not only most of the approaches that are currently in clinical trials include ones that utilize CRISPR as a nuclease editing platform, but there are others that are in clinical trials that involve some other editing. But I also want people to actually be accustomed to now hearing about base editing. So if you could imagine when we talk about gene editing, we're often thinking these are approaches that require a double-stranded DNA break. So if you could imagine the analogy of scissors cutting across the double helix of DNA, so breaking both strands, whereas base editing does not require double strand breaks and is actually capable of doing a single base pair conversion. So a much more specific alteration, and that these approaches are currently in clinical trials with blood disorders like sickle cell and thalassemia. And again, at least one approach is currently being submitted now and potentially could be approved by the FDA before the end of the year. There are a number of factors that are affecting outcomes for gene therapy. Just like I mentioned for stem cell transplants, the severity of thalassemia complications prior to transplant absolutely impact outcomes from gene therapy. And so even as one is just considering gene therapy or stem cell transplant, it is so important to think about one's overall health and one's organ health as it relates to thalassemia, as well as iron overload. There are multiple effective agents now, both oral and IV, for controlling iron overload. And so most of us will expect that a patient have optimal iron balance before undergoing these therapies just to ensure their outcomes. The degree of marrow ablation, how well did we do in using busulfan to make space and to get rid of defective cells, is also important, and we have actually laboratory tests that we can monitor to be sure that we're ablating effectively. The degree to which stem cells, that we give people an adequate number of stem cells, and the percentage of those stem cells that have been corrected or modified are also factors that are important in looking at the benefits. And then for the gene editing, having pancellular expression of the therapeutic outcome. Questions have been asked about age. Right now, we don't think that age is actually having a major impact, that there are patients who are having good outcomes, whether they're very young or very old, yet some have questions about whether or not younger patients might do better. We'll have to wait and see about that. Risk, I've mentioned the ones that are related to busulfan, including mouth sores, hair loss, potential liver problems. Graft failure, delayed platelet engraftment has been seen, but has not been terribly serious for patients undergoing gene therapy, including Zynteglo. Patients need to be monitored for clonal dominance or insertional oncogenesis in the case of Zynteglo. We've not seen that at all in the clinical trial setting. And off-target events is an additional complication potentially of gene editing. Infertility is largely related to the busulfan, which currently is standard for gene therapy in the current setting. So in conclusion, sickle cell and thalassemia are devastating red cell disorders that are caused by mutations in the same gene. And the stem cell transplants using sibling donors can be curative, but the risk and donor availability are limitations. The early gene therapy results have been very similar to sibling transplants and have been very promising for both conditions. The first FDA-approved gene therapy for thalassemia is here, and it's available for all ages and all genotypes in the United States. We believe that there's a possibility of additional FDA approvals for both gene editing and gene addition therapy for sickle cell later in 2023. And I'd like to thank you for your attention. Dr. Bailey, I can't hear you. Maybe others can.
Thank you so much. I was actually muted, so I appreciate that. I was saying, Dr. Thompson, thank you so much for your presentation. That was fantastic in covering the current treatment options available for patients with beta thalassemia and sickle cell disease in terms of cell transplant and gene therapy. We will now transition to Dr. Waldman to hear about childhood cerebral adrenoleukodystrophy and schizona. So, Dr. Waldman is an associate professor of neurology at the Perelman School of Medicine at the University of Pennsylvania. She is also the associate director of clinical in vivo gene therapy at CHOP and the medical director of CHOP's Leukodystrophy Center of Excellence. Dr. Waldman received her medical doctorate from Jefferson Medical College, and she completed her pediatrics residency at CHOP and child neurology residency at both CHOP and the Hospital of the University of Pennsylvania. She is a recipient of the National Multiple Sclerosis Society American Academy of Neurology Foundation Clinical Scientist Development Award. In 2005, she co founded the Pediatric Multiple Sclerosis Center at CHOP, and in 2015, she co founded the Leukodystrophy Center of Excellence at CHOP, where she now serves as the medical director. Dr. Waldman's primary research focuses on the development and interpretation of outcome measures for clinical trials in neuroinflammatory and neurodegenerative diseases. In 2021, she was appointed the Associate Director of Gene Therapy at CHOP. She also serves on the Neurologic and Ophthalmic Gene and Cell Therapy Committee for ASGCT. So, welcome, Dr. Waldman.
Thank you so much for having me. I'm delighted to be here today. I feel very close to our leukodystrophy families and our patients, and we're really excited about this therapy. I also, as you heard, wear a couple of different hats, combining my interest in these neurologic and neurodegenerative disorders and looking to the future of medicine with these gene therapies. So I will speak to you today about X-linked adrenoleukodystrophy, which is a neurologic disease that also affects the adrenal glands, involving the peroxisomes of the cell. And you'll see that demonstrated on the right side of the image here. The gene mutation is in ABCD1, which encodes a transporter, the adrenoleukodystrophy protein transporter, that brings fatty acids into the peroxisome for beta oxidation, bringing back a lot of chemistry. But when you have adrenoleukodystrophy, this transporter is defective and you get an accumulation of fatty acids, very long chain fatty acids that are present in the brain, in the adrenal glands, and can also be found and tested in the blood. So we can make a diagnosis very easily by measuring those very long chain fatty acids in the blood. Excuse me. Very exciting, hematopoietic stem cell transplant was first performed in 1982, very similar to what we just heard in the hematology space, and was published in 1984. So it was a very busy time in the 80s looking at these transplants for non-malignancies. Excuse me. But what's very interesting, it might make logical sense to everyone in what we just heard from Dr. Thompson about doing a bone marrow or hematopoietic stem cell transplant for a disease of the blood, for a disease of beta hemoglobin, like for diseases of the blood, a hematopoietic, a blood cell transplant makes sense. We actually don't know exactly why it works for adrenoleukodystrophy, because we are trying to correct the problem with this protein, and we have to think about how these blood cells, which can get into the brain to deliver, in theory, a healthy protein. It's not as logical in medicine, but it was tried, the bone marrow transplant tried in 1982, and it resulted in a reduction of that patient's very long chain fatty acids. Now, sadly, the very first patient who had the transplant did pass away, as this disease is relentlessly progressive, but our data has come a long way, and I want to walk you through some of that. So between 1982 and 1999, there was a decrease in survival among patients who were had an unrelated donor, but improved survivals if you had a matched sibling donor. So the data is not quite as strong as those hemoglobinopathies we just heard about, but still survival was improved in the last century when you had a matched sibling donor. We have additional data from the first decade of this century looking at a few other predictors of how patients with this disorder can do. And I just want to pause for 1 second. A transplant is not indicated for every patient with adrenoleukodystrophy. Adrenoleukodystrophy can present in many different ways. It can present rarely, but it can present with just affecting the adrenal glands and not involving the brain. Many of those patients ultimately will develop some symptoms of the arms and the legs eventually. But it can present in children with the cerebral or brain form, and in adults with a disease called adrenomyeloneuropathy, so more of a peripheral appearing disease. So not so much central to the brain, but in some of the areas and the nerves that as they exit the brain. So in the first decade of this century, we looked at different predictors of outcomes, including an MRI score, a clinical score, and the addition of an antioxidant. I'll come back to donor type. And notice that patients who had early disease, who were less effective, did have better outcomes. And comparing to the earlier data, again, the patients that had a matched sibling donor, very similar to the hemoglobinopathies, and echoed again in our data, that if you had a matched sibling, you did much better in terms of your outcome. And so we learned that the matched sibling is definitely the way to go, and that early treatment is critical to better outcomes after the transplant. Now, I do want to pause for a second, and this might echo some of the things that Dr. Thompson was bringing up, in that diversity among adrenoleukodystrophy is present. We now are very fortunate that many states in the United States will do newborn screening, similar to what we heard from sickle cell disease. And newborn screening, of course, is agnostic to race and ethnicity. So we're finding more and more families through newborn screening, and not every family we're very fortunate in the United States to have such diversity. Not every family is going to be able to find a transplant match should they need one. And underrepresented minorities have less of a chance of finding a match, as indicated in this graphic on the right. And we also have learned that transplant-related mortality is increased when you use an unrelated donor compared to a sibling, and even among some of these ethnic minorities, that there's an increase in these transplant-related mortality. So it's very important, and it was something that we actually said to the FDA, that we can't rely on a transplant if only one portion of our population is likely to have a matched donor in the national registries, and wanted the FDA to think about the fact that many patients in the United States who didn't have a match would not have a viable outcome for this disease. So enter ex vivo gene therapy. So I have a similar graphic, but a little bit different from what Dr. Thompson presented, but it's the exact same idea. So you mobilize someone's stem cells either through the bone marrow or through the peripheral collection of cells. You collect the stem cells, you do this ex vivo outside of the patient, entry of the gene into the cells that you've collected, and then you give them back to the patient. So here's our ex vivo gene therapy. And in adrenoleukodystrophy, similar to thalassemia, we're using a lentiviral vector. There's different types of these vectors. For ex vivo gene therapy, lentiviral vectors have been very successful. So enter gene therapy for childhood cerebral ALD. So this was called the STARBEAM study, and it involved this lentiviral vector in children that were 4 to 17 years of age. Again, they had to have early active disease, meaning that they had to have a low MRI score, a low clinical score, meaning that they were healthier than some other patients or had less symptoms than other patients. And they had to have gadolinium enhancement, so contrast enhancement on the MRI. And that is a sign that there is active inflammation or active disease. And again, I put in quotes the overall goal of the STARBEAM study, which the gene addition should result in the production of functional adrenoleukodystrophy protein, which is involved in the transport of the fatty acids into the cell for beta oxidation. Even for adrenoleukodystrophy, we need to use conditioning. So, and for this program, it was busulfan plus cyclophosphamide. And so we would wipe out the patient's own immune system in order to make room for the cells to be given back to the patient. So you take the cells out, you suppress the immune system, and give the cells back. So for this study, you were only eligible if you did not have a matched sibling donor. If you had a matched sibling donor, then you were recommended, just like in the hemoglobinopathies, for a standard transplant. So here I'm presenting the published data. There have been additional patients that have received this therapy, but I wanted to stick to just what was published for the purposes today. So the initial enrollment was 18 patients, although one was ultimately deemed ineligible. So there were 17 total patients that received this therapy. And 15 of the 17 were alive and free of major functional disabilities at the primary endpoint, so the amount of time that they initially reviewed the patient data. 2 patients died. So one had withdrawn from the study. I believe that he withdrew from the study because there was graft failure, that the transplant that it didn't take, and underwent a traditional transplant, and unfortunately had complications related to that traditional transplant and sadly passed away. And then there was another patient who experienced very rapid disease progression. You'll see that in a future slide after the patient was enrolled. As many of the patient families know, cerebral ALD is a fairly relentless disease that progresses quite rapidly. And even in those patients that we try to catch very, very early on in their disease course, can still have a fairly rapid disease progression. And this patient sadly had a rapid disease progression and died just shy of 2 years after the therapy from rhabdomyolysis and kidney failure and liver failure. Overall, the other 15 patients did quite well. And the safety concerns were really very similar to the related to the conditioning program, not so much the transplant or the lentiviral vector, but just a result of receiving the busulfan and the cyclophosphamide. And I've listed some of them here: a spinal fracture in one patient, viral cystitis. It's very common to have infections. You have a central line or a tunneled IV sometimes. Febrile neutropenia, we've wiped out your immune system, you get a fever, your immune system can't fight those infections, even just fever itself. Mucositis, so inflammation of the mouth and the esophagus. One patient had a seizure, which could have been related to the underlying adrenoleukodystrophy. Seizures are not that common, but can occur rarely in that disorder. Gastroenteritis, so vomiting, diarrhea, increased heart rate. So just some of the things that you typically see in the context of the myeloablative conditioning. There were some other safety events that I did not report that seem to be more consistent with adrenoleukodystrophy and progression of the disease, which I'm going to show you in here. So on the left, you'll see the neurologic function scale. So 0 is normal. And on the right is the actual scale where you get additional points for sort of disease progression. So some areas you just get a point if you have hearing loss or if you can't speak. Loss of communication, you get 3 points. And so you'll see as you go down to the motor skills that you have some increasing points. So this is the patient that had the just rapid disease progression and then died later. This is the patient that went into a different, had the allogeneic transplant. And then you can see these other patients, even a year and a half, 2 years later, some of them did develop a few of the symptoms on the neurologic function scale, whereas 12 patients in the study remained normal and did not have the development of any of the symptoms listed on the right. So most patients did quite well and did not develop the major functional disabilities that are listed on the right here. Now, with respect to MRI, there still was disease progression on the MRI, even many months after therapy. So on the left, you have a very similar graphic to the one before, where there's an increase in the MRI score showing an increased MRI disease burden for many of the patients. Again, this is the one that did very poorly. But even in many of the other patients, there is an increase in disease seen on the MRI. And on the right, you'll see gadolinium enhancement, which is a symbol of active disease and active inflammation in the brain. And you'll see that there's still active disease, even a year, 18 months, 2 years out after the transplant. So the reality in both of these slides, I'm just going to go back to this one for a second, is that you're doing a therapy while the disease is actively progressing. And I just want to make the point that we're all very hopeful that the therapy would halt any further neurologic progression, but that's not actually entirely realistic, as there were a few symptoms that still developed even, well, for this patient right away, but even a year or more after the gene therapy. And the same thing here, that there still is MRI disease progression despite treating patients very early in the disease. So time matters. So getting this transplant or getting the transplant plus gene therapy as soon as possible, knowing that there's still some disease progression that's happening as this takes time for it to work. So early therapy is key. Now, I do want to mention in long-term follow-up, there have been 2 cases of myelodysplastic syndrome, which is a blood cancer. And that has happened after Skysona in the clinical trials. And the timing has varied. One patient had it about 14 months after treatment, one 7.5 years later, which is very humbling in terms of long-term follow-up that's needed for any patient that receives gene therapy. So the cancer occurs because the lentiviral vector, the way it works is it integrates into dividing cells. But dividing cells that now have this, it was insertional oncogenesis, it inserts into these dividing cells and precipitates this blood cancer. So careful monitoring is needed. What's currently recommended is that we do a complete blood count, or CBC, at least every 6 months in the first year, and then annually after that, at the very least. There's also testing for clonal expansion. So this is a little bit more complicated in terms of looking at the effectiveness of the gene therapy over time. Now, interestingly, myelodysplastic syndrome is treated with a hematopoietic stem cell transplant. So, very humbling. After a patient undergoes gene therapy, they get to use their own cells. That was the whole idea here, to only have to go another an unrelated hematopoietic stem cell transplant due to a side effect of this therapy. So something that we have to continue to watch. Again, 7.5 years, one patient developed it. So, it's a little bit humbling in that sense, and that patients are going to need very long-term monitoring to look for this long-term side effect. Okay, so Skysona is indicated. So just similar to Zynteglo, this was approved in September, so 1 month after Zynteglo. So approved in September of 2022. It's indicated to slow the progression of neurologic dysfunction, and I hope I've conveyed that through the MRI and the neurologic function score, that it is not a cure, but slow the disease progression. It's indicated for boys who are 4 to 17 years of age that are eligible for a transplant, but do not have a matched sibling donor. Again, you're not eligible for a transplant if you don't have cerebral involvement. So again, you have to have either no or very few neurologic symptoms. That's the early stage of disease. You have to have an MRI score or a less score between 0.5 and 9, and quite honestly, ideally less than 5. So as you develop more disease burden, you get a higher score. And I'm showing here in these top images, this is a patient who has disease in the back part. It's called the corpus callosum. And you can see their pre-treatment MRI and then their post-treatment MRI. And here, this is key. This is the enhancement. This is the post-contrast involvement. You have to have active disease as indicated by this contrast enhancement. So these are the current criteria to be eligible for Skysona. But a few limitations of use that have come from the FDA and the package insert. So this does not treat the adrenal insufficiency. So patients need to be aware of that, and they still need to follow with an endocrinologist and get ACTH and AM cortisol tested. It is possible to have an immune response. So this still is a foreign material that's being injected into the body. So it's still possible to have an immune response. Skysona has not been studied in cerebral adrenoleukodystrophy that is activated by head trauma. So sometimes we have seen in mild head trauma or more severe head trauma that patients end up with gadolinium enhancement on their MRI. It is not clear whether Skysona would be beneficial in that case. There also have been some cases of Skysona that was used in patients with isolated pyramidal tract disease. This is a different MRI finding and not necessarily the indication for Skysona. So it's not sure, again, it is brain involvement, but not sure Skysona will be effective with this type of brain involvement. So still some questions in terms of some patient populations that might not be eligible for this. I will just mention Skysona currently costs $3 million. This does not include the cost of a transplant, which is also quite expensive. As you heard, patients need to be admitted for quite some time, and hospital admissions can be quite costly as well. So it's an expensive therapy. It will be administered at qualified treatment centers, similar to Zynteglo. So this won't necessarily be made available to all centers throughout the United States. And I will just note that one major commercial insurance policy, their member statement said that a member is eligible if they are unable to find a matched sibling donor, they have not received Skysona or any other gene therapy product previously, and they have not had a prior allogeneic stem cell transplant. So that's just one policy that is publicly available. So I just wanted to conclude with a few considerations. So Skysona is indicated for children without a matched sibling donor, similar to what you just heard for the hemoglobinopathies. Now, it's a little unclear, adrenoleukodystrophy being X-linked, it's not clear whether matched siblings who are also affected with ALD would be considered suitable donors. So as many patients and families know, not every patient in the same family has the same phenotype of disease. So if, for example, there's a female who is a carrier of ALD and is a perfect match, we have to give careful consideration of whether that would actually be an ideal match sibling as opposed to a female who does not carry the ALD gene. So a little bit more for us to think about in terms of the matched siblings. And I just want to reiterate, time to transplant is key. So with a traditional transplant, either a hematopoietic stem cell or bone marrow, it takes some time sometimes to find a donor, and it can take a few weeks to a few months to find a donor. And that can sometimes cause some delay with a traditional transplant. But it's important to note that with Skysona, it's going to take 60 to 90 days from the manufacturing time. So we would have to get insurance approval first, bring the patient in, collect the cells, ship the cells for the manufacturing, we get the cells back, and then we bring the patient in to start the conditioning and start the transplant. So this is not necessarily a faster option for families. Just because you're using your own cells, it doesn't necessarily mean that it's faster. So we recommend that patients engage with a transplant center early. So we at our site will refer to a transplant team for education to discuss risks and benefits of these therapies and to do HLA testing before the development of even cerebral disease. So a lot of times, as you heard, the cerebral disease develops after the age of 4. So we will often refer to a transplant center even at 2 or 3, establish care, have the discussions of whether a matched sibling is available, do the HLA testing, and even look in the unrelated, in the national donor profile to understand whether or not there is an unrelated or a sibling or an unrelated match. If we go through the unrelated match profile, so the national donor program, and we find that there is no suitable match, you can imagine that that would really strengthen the letter of medical necessity to the insurance company saying that, we already know that we're going to have a hard time finding an unrelated match and that we should probably move more quickly towards Skysona. So just to conclude, hematopoietic stem cell transplant with or without the gene therapy is an effective therapy for early active childhood cerebral adrenoleukodystrophy. And Skysona provides access to treatment for families without matched sibling donors, and we are hopeful that it would also allow more diverse treatment, greater treatment to our diverse population in the U.S. Transplant and treatment-related morbidity and mortality occurs with both treatments. So it's important to know the risks and benefits with the traditional transplant or a transplant in combination with Skysona. And these risks and benefits should be reviewed carefully with a leukodystrophy expert, someone that understands the disorder, a transplant team, and a Skysona qualified treatment center. So I want to thank you all for your attention as well. And that will conclude my presentation so that we can have a few more minutes for questions.
All right, Dr. Waldman, thank you so much for your presentation. That was very informative. So I'll now invite you and Dr. Thompson to join me in a panel discussion on these recently approved therapies. As a reminder to our audience, we encourage you to submit questions using the chat feature that you want to learn more about during this discussion. So for both thalassemia and cerebral ALD, you've highlighted that there are now multiple treatment options available to patients for each of these disorders, which depend on the presentation, disease progression, or availability of matched related donors. This is fantastic as this potentially increases the numbers of patients that could receive a treatment for the disease. But Dr. Waldman, I was wondering if you could speak more to the timing. You mentioned it with the timing of the diagnosis for a patient versus for when they can receive the transplant or their gene therapy. And you mentioned some of the considerations that caregivers and providers should know to help make the process faster. Dr. Thompson, is there similar considerations with thalassemia and for sickle cell that caregivers and providers should keep in mind once they have a patient that's been diagnosed?
Well, I must tell you, the urgency, I think Dr. Waldman's presentation sort of underscores the urgency when we talk about CALD. And that isn't the case for the hemoglobinopathies. And so it allows us to have robust and at times extended conversations with families to really be certain that this is the right treatment for them. Both sickle cell and thalassemia, talking primarily about thalassemia, they're associated with a shortened lifespan overall and significant morbidity. And so they absolutely are conditions where curative approaches are justified. I don't think that there necessarily is this urgency in time. And in fact, because we believe that medically we have the opportunity, we strongly encourage families really to think through what they feel about their current condition, their current status, to consider what the potential complications are, and to be sure that this is the treatment choice for them at that point in time in their family's life and in their child's life cycle. So a bit different, but still ones that we want to make sure that we have a very informed patient population. And so sometimes those conversations can start fairly early with your primary hematologist or neurologist. I think that they are people that by and large patients trust. And so I think that they have a tremendous role to play in referrals to patients for consideration of these treatments.
Excellent, thank you. So we do have a question from our audience. Were there any particular biometric considerations you would highlight for these gene therapy treatments, such as database, CRF design considerations?
I can talk to that one a little bit too. Why Dr. Thompson, reads the question and see if she has anything to add, because I saw it pop up while she was just talking. So it's a very interesting question. I was actually part of a CRF design process to gather data after these gene therapy treatments. So let me take a step back. As part of the accreditation to be a transplant center, and Dr. Thompson might be able to speak to this a little bit better since that mostly falls under hematology, but to be an accredited transplant center, I believe that those transplant centers all contribute to a central database where patients are followed. A couple of years ago, we all met to try to figure out how we were going to incorporate gene therapy into that similar program. And it's very humbling seeing that we have to monitor some of these side effects 7.5 or more years out, and can be quite challenging. So it's a great question about how we're going to monitor. What I will say is that program is very much geared to the monitoring of hematologic side effects or the engraftment. It's not so much set up to capture all the neurologic complications or outcomes. And to be honest, we don't really have the funding to do that. Transplant centers I can't speak to the funding that they have to add to these databases. But it's a great question. There's a lot of data that needs to be captured. But when you start capturing data like that, you also need some funding to do it, which can get a little bit complicated. I don't know, Dr. Thompson, if you have any other thoughts on collecting data after transplant.
Yeah, and so what I would say is that by and large, the primary organization that has been tasked with doing this is an organization called CIBMTR, which is the Center for International Blood and Marrow Transplant. But most of the data, if you can imagine, that CIBMTR collected have been on allogeneic transplants, and so autologous transplant data didn't necessarily lend itself to some of the forms, and so it certainly did require some adjustment there. There are also mandates about collection of information for allotransplants that was not there for autos, and so even today, submission of auto transplant data is voluntary. I think most of us think centralized data collection is important, and so, but I couldn't disagree that it does require time and effort on the part of staff to get this done. The trials for Zynteglo or for lentiviral vector gene therapies have always, from the outset, required long-term follow-up. And so the initial parent trial is only 2 years, but our patients were all asked to sign up for a total of 15 years follow-up. Fortunately, we have not lost a single patient of follow-up, that we've made that case from the very beginning. And the FDA is expecting that we do the same in the commercial setting. And so while I think many families are very enthused about cure and coming in and just getting it done, we want to make sure that they understand that there are things that we don't know yet. And so that we are expecting, and we would like them to understand that we will be contacting them for infrequent visits, but that we need to be in touch with them over the next 15 years. CIBMTR sites are accustomed to doing longer term follow-up, although I would argue it's probably not 15 years. But I think that, for instance, engaging some of the primary subspecialists, whether it's the neurologist or the hematologist, may be also helpful, because many of them have connections to be able to keep patients linked into care, to be able to do that long-term follow-up. We've been pretty pleased at the data collection efforts otherwise. I mean, they have not been terribly onerous, but yet really trying to actually make sure that we're doing the appropriate monitoring, looking for late effects, is also going to be something very important.
Thank you so much for your responses. We have time probably for one last question, also from the audience. So one of the audience members saw from the sample payer policy that includes criteria beyond the FDA label, such as inclusion of clinical trial inclusion or exclusion criteria. How can providers ensure all appropriate patients are still able to get timely coverage of a therapy?
I'm not sure if I think this is directed about Skysona. I can't be entirely sure. One idea that pops to mind, I don't have all the inclusion and exclusion criteria in front of me, but neuropsych testing is done. This is a cerebral disease. It's a brain disease. So I'm not sure if that's, for example, one of the things that's being that they're referring to, that you had to have a certain IQ in order to get therapy. And I don't remember if that's the particular example, but choosing one such as that, that was not necessarily in the label. But if it was something that was in the clinical trial, it's an interesting point. I think we don't have a ton of information about the patients that weren't included in the trial, and we're not yet sure if insurance companies are going to approve some things like that, and if we should be looking at, for example, an IQ pretreatment or some of these other things. I think it's a valid point, it's a valid question, and I think the more we can get to these patients early, and thank goodness for newborn screening, the more that we can get to these patients early, the more that we can prove whether they have a good match profile or unrelated match, the stronger letters to the insurance companies that we can write, and go from there. But we'll have to keep an eye on this to see if people are getting denied because of some of those additional criteria.
All right, thank you so much. And we're coming to the end of our Lunch and Learn. So again, I want to thank our speakers for giving thoughtful overviews of each disease and therapy, and for providing a perspective on the outlook of access for those within the various patient populations. I also want to thank our audience for attending this session. The recording will be available on the patient education website early next week, and an email will be sent once available. If you found this information useful, please share it with your network. We would also love to hear your thoughts on the session, so please fill out the brief 3-minute survey linked in the chat or accessible via phone by scanning the QR code on your screen. The next Lunch and Learn will be on March 30th, and a panel of speakers will explore roadblocks to developing a treatment, including possible program halts, regulatory holds, and safety and patient enrollment. Registration will be open on the ASGCT patient education site after this session. We hope you'll join us then. So thanks again, everyone, and have a great rest of your day.